Hi everyone, welcome to the session Introduction to Prostate Cancer and Primary Treatment Options. My name is Jenna and I am one of the program coordinators here at the Prostate Cancer Supportive Care Program. Today I'm joined by Dr. Jenn Locke and Dr. Ryan Urban. The PCSC program was implemented in January of 2013 and is funded primarily by philanthropic donations. We are very appreciative of the past one-time support from both government and non-government organizations. The Prostate Cancer Supportive Care Program is made up of 8 different modules that tackle different topics on prostate cancer. This is the first of 8 modules, Introduction to Prostate Cancer and Primary Treatment Options. And later on in this presentation, I'll be talking more about the other modules and how they can support you during and after treatment. This presentation will cover the following topics. First, the anatomy of the prostate and prostate cancer. We kind of like to call it Prostate Cancer 101. Then we'll go over the treatment options that are available in BC for prostate cancer patients. And finally, we'll provide an overview of the PCSC program and the different modules. I will now pass it over to Dr. Locke, who will talk more about prostate cancer and discuss some of the surgical treatment options available.
Thank you very much for the opportunity to present today. Today, I'm going to be talking about prostate cancer. Where is the prostate located? So the prostate's actually quite deep into your pelvis. It's located between the bladder and the urethra. In fact, the urethra actually courses through the prostate. It's just under your pubic bone and just in front of your rectum. So when we think about prostate cancer, we know it is a very common disease affecting 1 in 9 men in their lifetime. It's a slow-growing disease in most men, but can become more serious over time. However, if the prostate cancer is detected when it's still in the prostate gland, survival rate is nearly 100% if you're treated. So what are some risk factors for prostate cancer? We know that age and elderly is a risk factor, race with Black patients being higher risk of prostate cancer than Asian patients, as well as family history. We use something called prostate-specific antigen to screen for prostate cancer. So PSA is a normal enzyme made by the prostate gland. Normally, this enzyme liquefies the seminal fluid important in fertility, and it's present in the blood in all men that have a prostate. But in prostate cancer, it can be elevated, so we use it as a marker for prostate cancer. So how do we use it? Well, we do it with a combination of what's called the digital rectal exam. So that is examining the prostate for lumps or bumps. And we use both the PSA and DRE to screen for prostate cancer. However, we know there are other conditions that increase the PSA, and these include inflammation, trauma, and just general enlargement of the prostate. So we use it as a screening tool, but it's not perfect in this realm. You should note that if you do have prostate cancer treatment, PSA becomes a very good marker to follow for prostate cancer if there's any left. So compared to screening, using the PSA to follow the disease is a very reliable test after men are diagnosed and treated with prostate cancer. In fact, after surgery, the PSA should be completely undetectable. And after radiation, the PSA may become undetectable or stable low levels. So we use this as well as other tools to assess what are the best treatment options for you if you're diagnosed with prostate cancer. We use the T stage, which looks at the size and the extent of the tumor, the Gleason group, which is the pathological diagnosis under the microscope after a biopsy, the PSA value. If it's greater than 10, it's much higher risk, and a Capra score, which uses information plus age, the number of cores or number of samples taken at biopsy to calculate the risk of relapse after treatment is done. So looking in more detail at these features, we use this tumor or T staging to assess the extent of disease. So on rectal exam or on surgery, transurethral section of the prostate, we can actually determine how extensive the disease is. So if the cancer is just a small nodule on one side of the prostate, it's about a T2A type of disease. Whereas if it's gone into the seminal vesicles, and we can feel that on rectal exam, it's a much more extensive disease, and it's T3B. This helps determine the best treatment for patients. A very important feature is what the pathologists see under the microscope in the biopsy sample. So they look at the tissue and they see how differentiated it is. If it's differentiated and they look like prostate glands, it's thought to be a Gleason score or Gleason grade 1. Whereas if it's not well differentiated and looks quite cancerous, that's that red aspect on the slide, then it's a very serious or aggressive cancer, Gleason grade or Gleason score 5. So the pathologists look at this and they comment on the Gleason grade by including the most common and the second most common pattern of cancer on the biopsy specimen. And they assign this Gleason grade, generally 3, 4, or 5 to each. And so that would be most common of 3 plus a second most common of 4. That would be a Gleason score, 3 plus 4 disease. And the Gleason score is the actual sum of that. So that would be 7. And this is very important to determine the aggressiveness of the cancer and better guide your treatment options. This is because those patients that have Gleason 3 plus 3 or group 1 have a very good chance of living a long life with prostate cancer after radical prostatectomy. Whereas those with group 5 or Gleason 9 or 10, there's a much worse chance of survival from this disease, unfortunately. Nonetheless, it is still good if it's found localized to the prostate. So other information that are on your biopsy or pathology report, the number of cores that are taken or the number of samples taken from the prostate, obviously depends on the size of your prostate, but the majority of people get 8 or 9 cores taken. And the pathologist also includes this number, as well as the number that are positive, the percentage of each of those samples of amount of cancer, and the location of the positive core, which is important because it helps us determine best way to do a nerve spare during surgery in proximity to the cancer. And so these features really help us determine the risk of prostate cancer and the risk that it will come back after treatment. So these are the risk groups we utilize to counsel you on your best treatment options. And they include very low, low, intermediate, high, and very high. And this is based on the T category, the Gleason grade, the PSA, and the other features such as what we call PSA density, for example. So if you're diagnosed with a very low or low risk disease, active surveillance is the main mechanism of treatment, although in some patients they get prostatectomy or radiation, as these are other options. In intermediate risk disease, we do think that the disease will take your life over the next 10 years, so we do suggest active treatment, whether that be prostatectomy or radiation, and in rare cases, active surveillance. And in high-risk disease, sometimes patients not only go under radiation or prostatectomy, they also have what's called androgen deprivation therapy, which is an injection that reduces the testosterone in your body, and that starves the cancer cells and they go dormant. In very high-risk disease, we often do recommend ADT, and sometimes we do it just alone without prostatectomy or radiation. And that's not necessarily preferred because it's not a curative option, but instead it controls the prostate cancer cells. The majority of men are diagnosed with prostate cancer when it is localized to the prostate. In other words, when there's no evidence that the cancer is spread beyond the prostate gland, it's considered localized. And why this is important is because if it's within the prostate alone, it's treatable, curable, and in most men, we have some time to determine what is the best treatment option. So I will go over some treatment options for localized prostate cancer. I'm going to touch on active surveillance, prostatectomy, and then we'll hear more later about radiation therapy. So what is active surveillance? That means you've been diagnosed with a prostate cancer that's of low or very low significance, and we're watching you. So no treatment for now because the risk of cancer spread and death is very low. And so on this surveillance, we do rectal exams and PSAs every 3 to 6 months, and we repeat the biopsy within 12 to 18 months, and then intermittently, depending on some of the features we are looking at. There is an emerging role for MRI to assess the prostate in this spectrum. And so sometimes at 12 to 18 months, we get an MRI scan to see if there's any areas that are concerning. And then we can go after these with a targeted biopsy. So this is an example of a prostate MRI. You can see on a normal prostate, the gland looks what we call homogeneous or very similar throughout. But on the abnormal slide, you see in the circle there's an extension of what looks like an abnormality or a prostate cancer that's outside of the prostate gland. And so The MRI is very important to assess for growth of the cancer as well as areas of concern. An MRI does not diagnose prostate cancer. It needs to be followed by a biopsy targeting that area to better delineate the aggressiveness of that cancer there. So in about 10% of men, they have to come off active surveillance and actually undergo treatment. And so we do that for several criteria. For example, rapidly rising PSA, a change in the prostate exam. For example, there's a new nodule on exam or extension, an upgrade or higher volume of cancer on the biopsy. You go from Gleason score 3 + 3 = 6 to 3 + 4 or 4 + 4. That would be an indication to go off active surveillance. If there's a suspicious finding on MRI, like a PIRADS 4 or 5 lesion, that's another reason. And in some patients, they'd rather just have their prostate out or radiation have definitive treatment. And so that's another reason to go off active surveillance. So I'll touch a little bit on prostatectomy for localized prostate cancer. So surgical options for prostatectomy include the open surgical approach, the robotic surgical approach, and the laparoscopic surgical approach. With all of these, a general anesthetic is required, and the surgery takes anywhere from an hour and a half to 4 to 5 hours. In all of these surgeries, we do attempt to spare the nerves of the prostate if it is all possible, because it helps preserve erectile function and continence. But if the tumor is too large, then we would rather take the cancer out than spare those nerves. We know that there's no evidence that robotic surgery is superior to open radical prostatectomy in terms of survival, but there are ways we can actually compare and contrast them for you to help you make your decision as to what the best option is for you. Laparoscopic surgery is being performed in the province at this time, but we know that there are more and more robots coming across the province, and that might change the surgical options for you moving forward. So when we look at the surgical incisions, we see in the open approach, there's a lower midline incision below the belly button or umbilicus above the pubic bone. That's probably about 7 to 12 centimeters in length. Whereas for the laparoscopic or robotic surgery, we need ports for the robot arms to go into. And so they're much smaller incisions, but there's several throughout the abdomen. So when we remove the prostate, we surgically remove the prostate and sew the bladder back to the urethra. Now, your stay in hospital is about 1 to 2 days. There's minimal to moderate discomfort, requiring usually Tylenol and Advil for pain control and the occasional narcotic, such as hydromorphone. There's a catheter left in, so when we sew the bladder to the urethra, we allow it to heal by leaving what's called a catheter, which is this drainage bag you can see here. And there's a balloon inside the bladder that's holding it in place. And that's there for 1 to 2 weeks before. Furthermore, you need about 3 to 6 weeks off of work where there's no heavy lifting. But it is important to walk after surgery to get your bowels moving and to help you with your pain control. We know that all of these surgical approaches are very well tolerated. Recovery time is 4 to 8 weeks at most. We do take lymph nodes at the same time to see if there's spread of cancer to these. And the pathologist looks at all of the lymph nodes and all of the prostate in detail to better determine the aggressiveness of the cancer and your risk of it coming back. There's long-term benefits of removing the prostate as well as psychological advantages in the short term. And sometimes there's other treatments that are required after you've had your prostate out, such as radiation with or without hormone therapy. And that's mainly if the prostate cancer was left in terms of what's called a positive margin, or there was spread to the seminal vesicles or the lymph nodes at the time of surgery. One advantage of the prostatectomy over radiation is in patients that already have symptoms consistent with having an enlarged prostate, or also known as benign prostatic hypertrophy. So if you have troubles with a decreased stream, difficulties emptying your bladder, or getting up at night frequently and it's bothersome, perhaps the prostatectomy surgery is a better option for you than radiation. That being said, there are many different aspects of both that need to be factored into your decision when you're making the best decision as to what care you want to proceed with. In terms of the robotic prostatectomy, the Da Vinci surgical system is available at Vancouver General Hospital, and there are new systems coming up across the province that are available for robotic prostatectomy. This allows a surgeon to use 3D visualization and direct instruments from a console And you can see in this picture these little robotic hands, how they're dissecting the tissue planes, and it's quite good visualization. When we compare to open surgery, we know that there's a slightly shorter hospital stay, although open surgery is a pretty low hospital stay as well. There's a potential for earlier recovery of urinary control or continence. That being said, the long-term outcomes are equivalent. There's a very rare need for blood transfusion, less so than an open prostatectomy, and a rare chance of what's called a bladder neck contracture, particularly lower risk with the robotic than the open approach. A bladder neck contracture is scar tissue that forms when we sew the urethra to the bladder. And this happens in a very small proportion of men, but it requires another surgery to open that scar tissue up. So, what are the long term ramifications of surgery? Well, erectile dysfunction is something that's obviously near and dear to most of you. It obviously depends on your age and function level before surgery. We know that younger men with full erections have a better chance of full recovery from erectile dysfunction. But we also know that the impact of erectile dysfunction is very impactful immediately after surgery and can improve with time. And if a nerve spare is performed, then taking daily Cialis can help regain your erectile function. Another important outcome or side effect of surgery is incontinence. Most men experience incontinence right after surgery, so when the catheter comes out, you should have some pads. That being said, we know that Kegels before surgery and after surgery, particularly in the guidance of pelvic floor physiotherapists trained in this area, can help improve your continence over time. With only 1 in 10 men having continued level of incontinence, particularly with activity, movement, and cough, past a year. And total loss of control is very rare. In these circumstances, there are other surgeries we can perform to help you with your incontinence if it's quite bothersome. Other rare side effects of surgery include the need for blood transfusion from bleeding and that bladder neck scarring or bladder neck contracture that I spoke about, where you need another surgery to help you pee. And in very, very, very rare circumstances, rectal injury can occur during surgery, and this is devastating if it happens. So I will turn this over to the radiation oncologist to touch on radiation therapy as an option. And I thank you for your attention.
And now I'd like to invite Dr. Urban to talk about the radiation treatment options available.
Hi, everybody. My name is Ryan Urban. I'm one of the radiation oncologists at BC Cancer. And I'm happy to talk today about some radiation therapy options for prostate cancer. So how does radiation therapy work? Well, essentially, radiation interferes with the DNA of cancer cells. And when that DNA damage occurs, the cancer cells try to divide. And when they do that, they end up dying. The thing about cancer cells is they cannot repair as well as normal cells. So normal cells are able to repair between the fractions of radiation therapy, but cancer cells are not. And there's different ways of doing radiation therapy, both external beam radiation therapy, internal radiation therapy called brachytherapy, and then more of a novel technique called stereotactic body radiation therapy, or SBRT. And we'll touch on those each one. So first off, we'll start with external beam radiotherapy. And this is essentially high energy X-rays from a linear accelerator. You can see in the image, a patient on a couch and a big machine rotating around them, delivering X-rays at each individual angle. And to get this treatment, you need a CT scan to plan the radiation, which a radiation oncologist would arrange for you. And you can see the images on the bottom are an example of using the CT scan to plan the radiation therapy, depending on each individual's anatomy. And technically with external beam radiation therapy, these are daily treatments that can happen Monday to Friday, no weekends or holidays, for anywhere between 20 and 40 treatments, depending on your particular prostate cancer situation. So what are some external beam radiation side effects? Well, we can break it down into early side effects that happen during treatment and shortly after, and then also late side effects, which happen either months or years down the road. During treatment, usually this is tolerated well, but men can have fatigue. Radiation can interfere with the bladder and the bowel, so you can have irritative symptoms where it's difficult to empty the bladder or have some urgency to pee. And you can also have some looser stools due to irritation of the rectum. And usually those symptoms kind of generally accumulate during the course of external radiation therapy and last for about a week or two after before they start to settle. The other thing is erectile function can drop within the first 6 months, and then you can have some recovery, And then subsequently to that, men are subject to age-related decline in their erectile function. In terms of the long-term effects of radiation or late effects, they can have chronic changes to their bowel and bladder habits. Between 10 to 20% of men can have that long-term. The chance of causing inflammation that results in bleeding of either the bladder or rectum is rare. And the chance of leakage or incontinence is also quite uncommon with radiation therapy. Moving on to brachytherapy, which essentially just means an internal radiation treatment. There are different ways of doing this, but this particular example is inserting seeds into the prostate, which slowly emit radiation over time. And how we do this is we do an ultrasound procedure in this position with the legs and stirrups that are raised. We insert an ultrasound into the rectum and get detailed images of the prostate, and then plan a certain seed arrangement depending on each individual patient's prostate anatomy. And usually this is a day procedure. You come in, you meet with an anesthetist, get put to sleep or have a spinal anesthetic. The procedure can take anywhere from 2 to 3 hours, depending on how complex it is. And then patients are able to be discharged home following that. And there's 2 different types, which we'll both touch upon. There's the permanent implant, which is called low dose rate or LDR brachytherapy. And there's also the temporary implant, which is more high dose catheters, and that's called high dose rate brachytherapy or HDR brachytherapy. So here are some examples of each. On the left, there's LDR or low dose rate. Again, that's a permanent implant. So these seeds, depending on your size of the prostate, can be 70 to 130 titanium coated radioactive seeds that are much, much smaller than a grain of rice. And they have a radioactive substance that has a half-life of approximately 60 days. So once they are put into the prostate, half of the radiation is delivered within 60 days, and then 85% by 6 months. These seeds stay in permanently, and after about a year, there's no radiation activity at all. But you do have a card that you can go to the airport and fly with. And we do warn patients that we don't like to have prolonged contact, especially with infants or babies, but short-term contact and temporary contact is totally safe. And you're okay to be in public and sleep in your spouse's bed and have close contact, that's okay. In terms of HDR brachytherapy, so the high dose rate, so there is no seeds with this particular type of brachytherapy. Instead, we insert about 16 catheters into the prostate while you're asleep. And within that catheter, a radioactive source then goes into and stops at various positions within the catheter, within the prostate. And then that source comes out and goes into the next catheter and stops at certain positions, delivering a radiation plan. And that radiation plan can take anywhere from 20 to 30 minutes to deliver after the procedure is completed. At the end of the procedure, depending on the way it's planned, we take everything out, wake the patient up, and there's nothing left inside the prostate. Now, sometimes with HDR brachytherapy, we do have to do 2 treatments, not only one, particularly for men that are just getting brachytherapy, not combining it with either external radiation or other treatments. So that's one thing to consider as well. So what are the side effects of brachytherapy, both LDR and HDR? In comparison to external beam radiotherapy, brachytherapy usually causes a little bit more severe urinary side effects compared to external beam radiation therapy, which can be more gentle. And the reason for that is we get a higher dose of radiation within the prostate because we don't have to go through the body. But because of that, the rates of controlling the cancer are quite good. But what are some things that you may experience? You can get urinary frequency and urgency, and sometimes some burning pain when you pee. And that can last for several months with low dose rate brachytherapy because those seeds are emitting radiation over a slower period of time. After the procedure, there's about a 5 to 10% of requiring a catheter be re-put into the urethra. Usually that's temporary, and the risk is not large. About 15% of men can have worse function at about 1 to 2 years, but that improves to 5% at 3 years. And then the long-term risks, like having a stricture, which is a narrowing of the urethra because of scar tissue, is small. And the chance of having rectal side effects, either loose stools or having a rectal bleed or ulcer requiring surgery, are also small. And erectile function, usually men can preserve erectile function with brachytherapy, which anywhere between 30 to 90%, and a large component of that is dependent on your pre-treatment function and your age. In comparison to LDR, HDR brachytherapy, because that dose is delivered much faster, the side effects profile is very similar, but the side effects tend to occur a little bit more early, but also resolve faster because the dose is already delivered in a much faster period of time. And finally, stereotactic body radiotherapy, or SBRT, is sort of an emerging technique that we have more across the province now, but it is a form of external radiation therapy. The only difference is we deliver a higher dose of radiation per day over a shorter amount of treatments compared to external beam radiotherapy, which can be anywhere from 20 to 40 treatments. Usually, SBRT is given over 5 treatments that are usually done every other day. And this is currently available in selected BC cancer centers on clinical trial. Sometimes it does require you to do some extra procedures prior to starting in order for us to be more accurate. So some things are inserting fiducials into the prostate, which are little seed markers that allow us to line up in the correct position every day. And sometimes we also insert a spacer, which is a gel-like substance between the prostate and the rectum to avoid high-dose radiation to the rectum. The other component of treatment with prostate cancer that is not surgery, is not radiation therapy, is hormone treatment. And we call that in prostate cancer androgen deprivation therapy, or ADT for short. And essentially what that is a medication that's usually given first with some tablets and then some injections, either in the muscle or beneath the skin, that reduce the male hormone testosterone to 0. And the male hormone testosterone promotes prostate cancer to grow. So by reducing male's testosterone to 0, we can shrink prostate cancer and kill some of the prostate cancer cells, and ultimately combine this treatment with usually radiation therapy to improve the chances of cure. When ADT is given, depending on the prostate cancer risk, it's usually given for a period of anywhere between 4 and 24 months. It can cause many side effects, but those side effects tend to improve after ADT finishes and as the testosterone recovers back to what it was prior to going on ADT. And there is also a separate module that you can get more information regarding ADT and the side effects and how can they be managed as well. So in prostate cancer, basically we design our treatments depending on the risk of the prostate cancer. And there's a variety of factors that go into the risk, including patient factors, tumor factors, and things like the PSA level, how the prostate feels on examination, and what the pathology shows, so what's the Gleason score. And what we can do is categorize prostate cancer based on those different factors into low, intermediate, and high risk. And as you can see, as the risk of prostate cancer gets higher, we tend to add treatments together to improve the chance of cure. So for example, in low-risk prostate cancer, we have great success in curing prostate cancer with single modality treatments like external radiation, brachytherapy on the radiation side. But as we progress to intermediate and high, sometimes in certain situations, we do add other treatments. Like, for example, we can add external radiation with hormone therapy for a short term, or even in high risk, we can add external radiation with brachytherapy, with hormone therapy. So you can discuss with your doctor what is your risk category of prostate cancer and what treatment modalities and what combinations of modalities would be suited to treat. That's all from the radiation side. Thanks very much for listening to this presentation.
Besides this session, what else does the PCSC program have to offer? The Prostate Cancer Supportive Care Program has 8 different modules that tackle different topics on prostate cancer. The program coordinator's job is to assist patients in navigating program modules based on individual needs and desires. We recognize that not all modules are of interest to patients, nor may they be applicable at all times. So we like to say that patients can pick and choose the modules that they would like to participate in. Like I mentioned, there are 8 different modules that address topics relevant to the prostate cancer experience. Most of our modules have both a group education session as well as a clinic for more individualized recommendations and advice. We require attendance at education sessions prior to clinic appointments, and the reason for this is that the education sessions provide a really strong foundation of knowledge on that topic, and therefore when you go to your one-on-one appointment, you'll be able to spend more time talking about your own medical history and get more personalized advice instead of going over the basics again. If you have a partner, it is encouraged and recommended that they attend with you at any and all of our education sessions or clinics. And all of our modules are offered both in person and virtually. So our education sessions are only offered online. However, our one-on-one clinics, you can either attend our clinic in person or you can have a virtual appointment with one of our clinicians. Like I mentioned, these are the 8 different modules that we offer, and I'll go through them one by one. Our second module is managing the impact of prostate cancer treatments on sexual function and intimacy. This module has 2 different parts to it, the education session and the clinic. The education session is delivered by one of our sexual health nurses, And in that session, they talk about what's been happening to your body post-treatment and some of the sexual side effects that you may be experiencing. Then they will also talk about the different options for different therapies that may help manage some of those sexual side effects. And these options go beyond the standard Cialis or Viagra that you might have heard of for standard ED treatments. And then once you attend that, you would attend a clinic appointment, which is a one-on-one appointment with one of our nurses. And in that appointment, they'll review your medical history and work with you to find a therapy or a solution that works best for you. If you are partnered, it is encouraged that they also attend this module with you. There are two different components to our sexual health module. The first, of course, is our in-person or virtual clinic, which includes the monthly education session, as well as 7 face-to-face visits with our sexual health clinician for personalized care. Alternatively, we also have our online share clinic, which is an initiative in partnership with the True North group in Toronto. And this is an online personalized educational experience or platform where you can access educational resources and communication with a sexual health coach to go over educational resources at your own pace. And we really recommend this share clinic in conjunction with our in-person and virtual clinic so that you can get further support in between appointments. Our third module is our exercise for prostate cancer patients, which is a module that we recommend for all of our patients that come through our program to promote overall well-being and good health. This is delivered by a certified exercise physiologist who is available for 5 one-on-one appointments to assess fitness level and exercise needs. First, we have our education session where our exercise physiologist will talk about why exercise is important for prostate cancer patients, specifically what types of exercises you should be doing and how often you should be doing them. And then once you attend that session and meet with our exercise physiologist one-on-one, they'll go over your medical history and develop an exercise prescription that's best suited for you based on anthropometrics and other conversations that you have in that appointment. And this is just a diagram showing sort of the flow of the clinic and how you'll be followed up every 3 months up to a year. Our fourth module is recognition and management of treatment-related side effects of androgen deprivation therapy, otherwise known as ADT or hormone therapy. This module is specifically for patients who are currently on ADT or who are planning to start ADT soon. The education session is delivered by our nurse practitioner, and in that session they talk about the medication itself, how it works, who needs it, what are the side effects, and how to manage them. We know that ADT has a very different side effect profile than what you've just heard with surgery and radiation, so we believe it's important that patients who are on this medication are aware of the possible side effects. And it doesn't mean to say that you will get all of them necessarily, but it's just good to be aware of what may happen while on it. And again, if you are partnered, we encourage partners to come to this session as well. And then for any patients who are really struggling with specific side effects and being on that medication, we do offer one-on-one appointments with our nurse practitioner, and they can sit down and come up with ways to help manage those side effects and prescribe if necessary. Our fifth module is our pelvic floor physiotherapy for bladder and bowel concerns. Our pelvic floor physiotherapy clinic has 2 parts again, our monthly education session and our clinic. In the education session, our physiotherapist talks mainly about Kegel exercises and the importance of strengthening the pelvic floor muscle to help with urinary incontinence post-treatment. Learning how to do Kegel exercises can be difficult just because it's a muscle in the body that we can't see. So our physiotherapists provide really good tips and strategies to make sure that you're doing them correctly. Once you're about 3 months post-treatment or 12 weeks, if you still find that you're experiencing any incontinence, we encourage you to reach out to us and we'll be happy to book you in with one of our physiotherapists for a one-on-one appointment. The reason that we wait about 3 months for that appointment is because there's a lot of recovery from treatment that happens within those first 3 months. So we just want to make sure that you're fully recovered from your treatment. And also a lot of patients do experience significant improvement. So we just want to make sure that you actually need the appointment before we book it. In the one-on-one appointments, our physiotherapists will go over different behavioral and cognitive techniques to make sure that you're doing them correctly and to help improve the incontinence. I did mention before that urinary incontinence is a common side effect of surgery. However, sometimes patients who undergo radiation treatment may experience bowel incontinence as well. And just know that our physiotherapist can also help with that, and we'd be happy to book you an appointment for that. And each of the sessions are individualized to meet each patient's specific concerns. So they'll go over your medical history and work with you to come up with strategies that work with your lifestyle. Our sixth module is our counseling services. We know that getting a diagnosis of prostate cancer is a difficult thing to hear and a difficult thing to experience. A lot of different emotions can come up through this process, whether it's fear, loss of control, anger, sadness, etc. And we just want you to know that we have a module that's there to support you if you do want to talk to somebody. Some patients find that the side effects from treatment as well may impact how you feel about yourself and your identity and ability to undertake usual activities and roles. And so our clinical counselors are able to support you with this. They can be there to have somebody to talk to who are aware of what the prostate cancer experience is like. And they can also provide information and resources in the community that can support you outside of the appointment as well. So we offer complimentary, private, and confidential clinic appointments for all patients, as well as their spouses or partners with our counselor. Patients can either attend the appointment alone, or if they wish to bring their partner, they can do that as well. Our seventh module is our metastatic disease management. So this is delivered by either a medical oncologist or a nurse practitioner. This is specifically for patients who have been given a diagnosis of metastatic prostate cancer. So it's no longer localized within the prostate and it's spread to other areas in the body. This session will talk a lot about the treatment and the medication that patients who have metastatic disease will be on, and understand the disease characteristics and natural history of metastatic disease. And our eighth and final module is our nutrition advice for prostate cancer patients. This is another one that we recommend to all the patients that come through our program to encourage a healthy lifestyle. And we get a lot of questions about different diets and supplements, and what you should and shouldn't eat when you have a prostate cancer diagnosis. And our registered dietitian is the perfect person to ask those questions to. They deliver a monthly education session that talks all about what foods you should or shouldn't eat, different supplements, and what it means to eat a healthy lifestyle and how that can support you throughout your diagnosis. If you have specific questions or diet concerns, you can also meet with our registered dietitian one-on-one in an appointment. And they can tailor healthy eating recommendations based on your personal food preferences and, of course, other health conditions that you might have as well. There are other treatments for prostate cancer that we have not discussed in this session. Some of these therapies you might have heard before. These can include cryosurgery, high-intensity focused ultrasound or HIFU, or proton beam radiation therapy. And there are two reasons that we don't discuss those therapies in this session. The first is that none of these treatments are covered by BC Provincial Health Insurance. So if you were to seek out these treatments, you would have to go out of province, most likely, and if not out of country, and also pay out of pocket. The second reason is that there's no long-term data to support that these treatments are superior to surgery or radiation that has been previously discussed. What that means is that although maybe there's some promising research in the short term, enough time has not passed to gauge if these treatments are effective long-term. And that's also the reason that they're not covered by BC Health Insurance. However, if these are treatments that you are interested in learning more about, I would encourage you to reach out to your physician to learn more. After treatment, how do you know whether the treatment is working or not? You will, of course, have follow-up visits with either your surgeon or your radiation oncologist. And in those appointments, they will make sure that you follow up and do a blood test for your PSA. With surgery, because PSA is only produced within the prostate, once your prostate is removed, your PSA should in theory be undetectable after 6 to 8 weeks. With radiation, it's a little bit different because the prostate is still within your body and it usually doesn't reach an undetectable level. However, there are thresholds that your radiation oncologist is aware of, and they'll monitor to make sure that your PSA is within that threshold. And of course, if you're dealing with any difficult symptoms after treatment, you can also get support from your physician as well. If you find yourself in a position where the cancer has come back after treatment or there's been a reoccurrence, there are other treatment options available for you. And this would be something that you would discuss with your physician. Some of these options include salvage external beam radiation, salvage prostatectomy, androgen deprivation therapy, and sometimes there are also clinical trials available for relapse. And just to note, the term salvage in these instances just means that it's occurring after your primary treatment. So it's not necessarily different, but it's just not occurring first. Speaking of clinical trials, through the Vancouver Prostate Centre and BC Cancer, patients have access to clinical trials for all stages of prostate cancer. If it is something that you're interested in pursuing, it is important to discuss the pros and cons of being in a clinical trial with your physicians, families, and friends before you agreeing to participate. If you ever are approached for a clinical trial, just know that regardless of your response, it won't impact the quality of your care. So make sure that it's a decision that is right for you. Follow up with your physician with what you've heard in this presentation, whether that be your family doctor, urologist, and/or radiation oncologist. If you're interested in further resources, here are two that we would recommend. The first is the Vancouver Prostate Centre, and that's their website and their patient telephone line. And second is the BC Cancer website, which has a lot of excellent patient resources on it, as well as their patient queries phone line if you'd like to get in touch. If you are looking for peer support and to meet with other prostate cancer patients who've gone through the same thing, the Prostate Cancer Foundation of BC organizes all of the peer support groups across the province. If you visit that website there or give them a phone call, they'll be able to direct you to the support group closest to you. They offer these support groups both in person and online as well. If you are interested in booking any education sessions or clinic appointments, please reach out to our program coordinator, Judy. Her contact information is on this slide. Thank you so much for watching.